Cardiac arrhythmias are one of the most frightening complications of pregnancy. They can occur in a normal heart and also in a structurally abnormal heart during pregnancy. We have to recognize these complications early and treat accordingly, otherwise the outcome can be very serious. To talk about these things, we have got an excellent eminent speaker, Dr. K U Natarajan. He is the head of Department of Cardiology and Electrophysiology, Amrita Institute of Medical Sciences. Over to you.
Thank you. At the outset, I thank the Kochi branch of the Indian Association of Physicians for having invited me for this very important CME on medical emergencies in pregnancy, encompassing multiple fields of medicine. The previous talk was really extraordinary. So, can I have the slides? So, the talk was on both irregular heart rate and also a small extra caption on heart failure in pregnancy was also part of this particular talk. So, we will go through the following aspects: cardiac arrhythmias complicating pregnancy with a practical approach in mind. The field of cardio-obstetrics, a collaboration between the fields of cardiology and obstetrics. What are the physiological changes in pregnancy, the heart diseases complicating pregnancy, the WHO classification of heart diseases based on maternal safety, heart failure in pregnancy in particular, a specific focus on peripartum cardiomyopathy, the definition, the signs and symptoms, the treatment, the prognosis, and the risk stratification for subsequent pregnancy in patients with peripartum cardiomyopathy. So the first half of this particular talk I'll devote to cardiac arrhythmias and the later half to heart failure in general and a few aspects about peripartum cardiomyopathy. And we'll also go through some illustrative real-life case examples as we go along. Addressing the issue of irregular heart in pregnancy, I'll talk about a recent patient that I saw in the OPD a couple of days back, a 27-year-old lady who had an IVF-based pregnancy 6 months ago, had palpitations during that pregnancy in first trimester, and she had an abortion. At present, 2 days back, she came again with an IVF-based gestation of first trimester with minimal palpitations on effort, which she had in the previous pregnancy as well. She was detected to have irregular pulse by the obstetrician, and I will show you the ECG now, and it was referred for cardiac evaluation. If you see this ECG, these are sinus beats, the narrow QRS complexes. This is one sinus beat, this is another. These are wide QRS complex ectopic beats, and you will all agree with me when I say these are ventricular ectopic beats because they are wider in QRS duration and they are all occurring in couplets. 2 consecutive ectopic beats, we use the word couplets. Anything 3 or more, we call it non-sustained ventricular tachycardia. So this patient had a structurally normal heart and echocardiography and frequent ventricular ectopics, and this was the reason this patient was referred for a cardiology evaluation. And ectopic beats are quite common in pregnancy. This patient was rightly started on tablet metoprolol 25 mg BD, which is very safe in pregnant patients. Beta blockers are one of the most safe drugs in pregnancy, particularly propranolol and metoprolol. Atenolol should be avoided because it causes intrauterine growth retardation. So it is almost a forgotten drug in the context of pregnancy. So metoprolol was given for this patient, which is very safe. And she had a Holter monitoring, which is a 24-hour or a 72 hours extended ECG recording that you are aware of. And this is during the Holter recording. Like we saw in the ECG, you see multiple VPCs in couplets. And what is important to understand is 22% of the beats were ventricular ectopic beats. We use the term VPC burden, ventricular ectopic burden. For every 100 beats, how many beats are ectopics is what is called the ectopic burden. In this case, it was 22%, which is quite significant. So, in addition to beta blockers, we added the next safe drug in pregnancy, that is flecainide, which is available in our country. 50 mg twice daily was added. This can be safely given in pregnancy. In fact, high dose flecainide is given to mothers who have fetal cardiac arrhythmias like supraventricular tachycardia. It crosses the placental barrier. It can have antiarrhythmic effect even on the fetus. So it is so very safe in pregnancy. So 2 safe drugs have been added to this patient, and this is the ECG during follow-up. A 12-lead ECG does not mean anything. You have to do a prolonged monitoring to know the arrhythmia suppression. But for the first time, we see sinus rhythm in this patient without ventricular ectopics, which is quite reassuring, and this patient was asymptomatic. So that was a case that I saw 2 days back. Coming to the burden of palpitations and arrhythmias in pregnancy, there are a lot of changes which happen in pregnancy which predispose to cardiac arrhythmias. There is vasodilatation, there is increased cardiac output, there are structural changes in the cardiac myocytes, and there is an increase in the autonomic tone. All these happen physiologically in pregnancy, and all these aspects can increase the chances of palpitations. Most likely sinus tachycardia, which is very benign. You'll agree with me that is the commonest arrhythmia in pregnancy. And of course, following sinus arrhythmia, sinus rhythm, sinus tachycardia, sinus arrhythmia, and ventricular and atrial ectopics are all due to this particular phenomenon which happens in pregnancy. And most of these arrhythmias, fortunately, are quite benign. And if you look at the increase in the rate, it is often around the second trimester. The physiological increase in the heart rate is maximal. And that is why these arrhythmias are quite common in the second trimester of pregnancy. What is the prevalence? As I already told you, the most common cause is sinus tachycardia, followed by atrial and ventricular premature complexes, which contribute to more than 50% of palpitations in women during pregnancy. Unfortunately, as I already told you, sinus tachycardia and ectopic beats are quite benign. There is nothing to be alarmed about unless the patient is symptomatic. We should give drugs like beta blocker. If still refractory, drugs like sotalol and flecainide, which are quite safe in pregnancy. And most of the time, these arrhythmias do not merit treatment. The exception being high VPC burden, like I showed you in the clinical example, 22% was the VPC burden in that particular case. And there has been a steady increase in cardiac arrhythmias over the last 20 years because of advancing age of pregnant mothers and comorbidities like hypertension, obesity, so on and so forth. The previous speaker spoke about fatty liver, which is quite common in the current population. These all contribute to the increasing. But the fact of the matter is that the frequency of arrhythmias is about 150 per 100,000 pregnancies. So it's not that very common. And the commonest arrhythmia is atrial fibrillation. Among the sustained arrhythmias, I am not talking about sinus tachycardia and ectopic beats. Among the sustained arrhythmias, atrial fibrillation, followed by what is called paroxysmal supraventricular tachycardia, which is a regular narrow QRS tachycardia. That is also a common arrhythmia which can happen in pregnancy. How do you approach arrhythmic symptoms in a pregnant patient, and what are the arrhythmias that can occur in pregnancy? I have already alluded to. The commonest things are ectopic beats and sinus tachycardia and sinus arrhythmia, which are very benign. 75% of the arrhythmias are quite benign. And only the remaining 25% can be supraventricular tachycardia, like AV nodal re-entry, atrial fibrillation, and of course, ventricular ectopics, ventricular couplets, non-sustained ventricular tachycardia, and sustained ventricular tachycardia. Fortunately, occur very less compared to these benign arrhythmias. And the presence of structural heart disease, of course, increases the chance of having these sustained arrhythmias. I will show you some typical examples of ECGs and common arrhythmias, and all of you should be aware of these things. This is an example of a sinus tachycardia. There is a P wave before every QRS complex, and the rate is 150. The QRS complex is narrow. This is the common arrhythmia in pregnancy, that is sinus tachycardia, very benign. These are atrial ectopics. Some of these beats are premature and the QRS complex is narrow. Typical example of frequent atrial ectopics, again common in pregnancy, again benign. These are ventricular ectopics, wide QRS complexes, like the case example that I showed in the beginning. These are ventricular ectopics, again they are benign, unless it occurs in patients with structural heart disease, like for example hypertrophic cardiomyopathy, dilated cardiomyopathy, valvular heart disease, so on and so forth, or increasing ventricular focus burden, more than 20% for instance. And this is an example of irregular narrow QRS tachycardia, the commonest arrhythmia, atrial fibrillation. And this is what I told you, paroxysmal supraventricular tachycardia. This is the narrow QRS tachycardia. The rate is about 200 per minute and you don't see P waves. So this is not atrial fibrillation because this is a regular tachycardia. We use the term paroxysmal supraventricular tachycardia. And one of the drugs which is very useful and relatively safe, of course it needs monitoring both of the mother as well as the fetus, is injection adenosine. If you give injection adenosine 12 milligram, this tachycardia will abruptly terminate. But it's good to monitor both the fetus and the mother in terms of cardiac rhythm. And this is an example of a white QRS tachycardia, that is ventricular tachycardia. How do you approach arrhythmia during pregnancy? History is very important. Symptoms, the gestational age, the presence or absence of structural heart disease, etc. Of course, clinical examination and ECG and echocardiography are quite vital in these patients. How do you assess these arrhythmias? The first question to answer is the patient hemodynamically unstable? An atrial fibrillation with fast ventricular rate, a paroxysmal supraventricular tachycardia, though they are often stable, if a patient is hemodynamically unstable, there is no question this patient should be electrically cardioverted, and cardioversion again is safe in pregnancy. You don't have to worry about, you are worried about the hemodynamic instability. Cardioversion is safe. If the patient is hemodynamically stable and if the arrhythmia is benign, like ectopic sinus tachycardia, you have to reassure the patient. You don't need medications, and oftentimes conservative approach is the answer, which I have already told you in the beginning. Is the heart structurally abnormal is the next question. And if the patient the heart is structurally normal and the arrhythmia is hemodynamically stable, most of the times in first trimester, try to avoid drug therapy. And if at all you want to give drugs, avoid teratogenic drugs. I repeat, stable arrhythmias, hemodynamically stable arrhythmias, whether there is structural heart disease or not, do not treat as far as possible in the first trimester and reserve treatment to the second and the third trimester. And you should give drugs that are safe in pregnancy. I'll talk about the drugs which are safe in pregnancy. There is the FDA classification of drugs based on maternal safety. X is contraindicated in pregnancy. That is, drugs like ivabradine, drugs like dronedarone are contraindicated in pregnancy. Amiodarone should be used with caution. It is class D drug. Of course, A, B and C can be used. Beta blockers are safe, particularly metoprolol, propranolol. Antiarrhythmics like sotalol and flecainide, procainamide, not available in India, are quite safe in pregnancy, which we should use. And a word about management of atrial fibrillation, I already told you. Instability, cardioversion. If the patient is stable, you can give drugs to control the rate like beta blockers, digoxin, verapamil, again safe in pregnancy. If you want to maintain sinus rhythm, the drugs to rely on are flecainide and sotalol. They are again safe in pregnancy. Paroxysmal supraventricular tachycardia, if the patient is unstable, cardioversion. If the patient is stable, the BP is normal, the first line drug is adenosine. The second line is again IV beta blocker. And long-term suppression is with beta blockers or with digoxin or with verapamil, again safe in pregnancy, particularly in the second and third term. Ventricular tachycardia, again if unstable, cardioversion. If the patient is stable, IV lidocaine is very safe in pregnancy. Second line is drugs like procainamide, not available in India. Quinidine is available in India. If the patient is drug refractory, you can think of other options. A word about bradycardia. Oftentimes we get consultations from obstetrics for bradycardia. It may be a congenital complete AV block, like you see here. There is complete AV block here, and the rate is around 40 per minute. And this patient has always been asymptomatic till the patient came to you, and the patient continues to be asymptomatic most of the time. So congenital complete AV block in a pregnant woman is usually well tolerated and permits continuation of pregnancy. You don't have to be bothered. If symptomatic, you can refer the patient for a permanent pacemaker implantation, particularly in the second trimester with minimal exposure to X-rays. In the second trimester, it can be done. Very rarely have I done a pacemaker for a patient during pregnancy. So we talked about the cardiovascular changes during pregnancy, the physiological changes, the prevalence of arrhythmia in pregnancy, some ECG examples, the option of conservative treatment in most patients, and safe pharmacological choices of medicines in pregnancy, and the treatment of sustained arrhythmias. I already algorithmic approach. Cardioversion is safe in hemodynamically unstable patients. and the importance of fruitful collaboration between the obstetrician and the cardiologist, which quite often happens in our department in Amrita Institute. And most palpitations in pregnancy are benign, often due to ectopics or sinus tachycardia, and the rarer and more sustained arrhythmias warrant vigilant evaluation and management. Careful consideration must be given to the stage of gestation and hemodynamic status of the patient, and one should be familiar with drugs that are safe both to the mother and the fetus, and the importance is to avoid these drugs in the first trimester as far as possible, but you can lower the threshold in the subsequent stages of pregnancy. In the next 5 minutes, I'll talk about heart failure in pregnancy. Pre-conception screening is important. Managing pregnancy with suspected heart disease is very important, and that is the importance of a team between the social worker, anesthesia, the obstetrician is of course the nodal point, and of course we also come into the picture. That is what is called the cardio-obstetrics, a specialty which is evolving. We'll talk about a patient, a 23-year-old female, a primary gravida, no known cardiac disease so far, comes with pregnancy in the early stages, that is 8 weeks. Effort intolerance, nocturnal breathing difficulty due to what is called the so-called third year MBBS paroxysmal nocturnal dyspnea. Refer to cardiologist correctly from the antenatal clinic. We do a clinical evaluation and confirm severe mitral stenosis. The valve area is 0.7. Mitral stenosis and aortic stenosis are not good things to have. They come under the 4th category in the WHO classification, and you should preferably avoid pregnancy in these patients. So this patient underwent what is called we counsel this patient for medical termination of pregnancy because it is very early stages and it comes under the WHO class 4, and this patient underwent medical termination of pregnancy followed by a balloon mitral valvotomy for relief of mitral stenosis. She underwent uneven full second pregnancy subsequently and delivered a healthy baby later on. So that was the case of a condition like mitral stenosis, which is not safe in pregnancy, and you should preferably consider medical termination and then consider relief of mitral stenosis and then plan the pregnancy later on. Moving on to patient number 2, a primary gravida once again, 4th month of gestation, class 2 effort dyspnea, again has severe mitral stenosis, but it is quite advanced pregnancy. And so we take this patient, this is a typical type mitral stenosis, a very fish mouth like mitral valve on the echocardiography. The valve area is 0.7, tight mitral stenosis, very high gradients across the mitral valve. This patient was started on diuretics, beta blockers, kept on close follow-up. After completion of the 2nd trimester, to reduce the radiation risk to the fetus, we took this patient for balloon mitral valvotomy during pregnancy. Unlike the previous example, I won't go into the details. I'll show you some interesting fluoro images. That is how we puncture the septum and enter the left atrium. And then we take a balloon across the right atrium to the left atrium because we have to access the left atrium. And this is the balloon procedure being done here. You see a balloon which is crossing the mitral valve, and the balloon, I'll just fast forward it, and this is the balloon across. We dilate this balloon across the tight mitral stenosis, and all this is happening in a pregnant mother. And you can see the balloon inflating, a waist is forming where the mitral valve is stenosed, and you see that the balloon completely abolishes the waist when the balloon is fully inflated, and the mitral stenosis is relieved. You see a completely open mitral valve. This lady underwent a subsequent continuation of pregnancy and had a safe delivery. And a word about peripartum cardiomyopathy before we end, because that is another important area that this is the WHO classification. Aortic stenosis, mitral stenosis, severe left ventricular dysfunction and pulmonary arterial hypertension are contraindicated in pregnancy. This is contraindicated. A word about peripartum cardiomyopathy. Again a case. A 29-year-old lady presented with frank congestive heart failure with class 2 dyspnea in the last gestation. The ECG was kind of normal. There was severe left ventricular dysfunction, as you can see here. hardly ejection fraction of about 15%. And there is mitral regurgitation, severe. You see the cross section of the LV, there is hardly any contraction. So in view of refractory heart failure, she was listed for transplantation. I think this patient probably died and lost to follow-up. What is the definition for peripartum cardiomyopathy? EF less than 45%, occurrence during the end of pregnancy or the months following delivery. There is no other identifiable cause of heart failure, and the incidence is fortunately less. The pathogenesis is linked to a fragment of prolactin that is responsible, and the oxidative stress fragments the prolactin from 23 kilodalton to a dangerous 16 kilodalton fragment, which is responsible for the entire pathogenesis, and that brings about the role of bromocriptin. So as obstetricians and cardiologists, we should be wary of the symptoms of peripartum cardiomyopathy, the differential diagnosis, and the use of natriuretic peptides. The elevated natriuretic peptides and a fall in the ejection fraction make the diagnosis of acute peripartum cardiomyopathy likely. The management is the board scheme. Bromocriptin is a very useful drug in this condition. And the prognosis, the myocardium fortunately recovers in about 50% of patients. Subsequent pregnancies, if the myocardial recovery is good, the risk is lesser. However, if there is persisting LV dysfunction, it is better to avoid subsequent pregnancy. And I will end this talk by saying that cardio-obstetrics is an evolving specialty. A fruitful collaboration between cardiology, anesthesia, and obstetrics makes life very important for patients with heart disease complicating pregnancy. And all these fields are important, right from pre-conception to the end. Cardio-obstetrics as a collaborative team is the need of the day. Together, you, me, all of us together, we can make a big difference to patients planning pregnancy or who are already pregnant with a wide range of underlying cardiovascular diseases. Talent wins games, but teamwork and intelligence wins championship. Thank you very much for your kind attention.
Thank you, Dr. Natarajan, for having gone through the various forms of arrhythmias, the failures, cardiac failures, how they can be treated. You have mentioned that cardioversion is a safe procedure at all stages of pregnancy. You can use metoprolol, ficamide, and adenosine. And you have completely gone through the whole list of medicines that can be given. I was just wondering, is there any congenital heart disease patients who come up with post-surgery, who come up with pregnancy?
That's an excellent question. Grown-up congenital heart disease, either treated or untreated, we commonly come across. Professor Radhamani will agree with me that we have a very eminent team of pediatric cardiology department. Repaired congenital heart disease, not the very complex ones like Fontan surgery. For example, an operated ASD or an operated VSD or an operated tetralogy of Fallot with no residual defects is almost like a structurally normal heart. Unoperated mild congenital heart disease, for example, atrial septal defect without pulmonary hypertension, a small VSD. These are all highly tolerated in pregnancy. In the interest of time, I didn't show you, it is actually WHO class 1 and 2. Unoperated congenital heart disease like ASD, VSD without pulmonary hypertension, they are again tolerated. So we do see cases who are operated as well as unoperated, which can safely undergo pregnancy. With of course, the collaboration with the pediatric cardiology department also, provided there are no residual defects of magnitude and also pulmonary hypertension. And complex defects needing Fontan surgery, etc. may not be a great option. Having said that, pulmonary hypertension also can be in the advanced stages of pregnancy. We have excellent drugs now. We have the ambrisentan, we have the phosphodiesterase inhibitor, we have selexipag, which can all be used to reduce the risk of pregnancy. So it's possible, but better avoided.
Thank you, Professor, for that comprehensive and excellent talk. Just want to, this one cardiac problem is one of the indirect cause of maternal death. And routinely we don't do a echo when the patient comes to the antenatal clinic. What is your take on that? Whether should we do a echo, because most of the patients present a bit late and majority of them may not be showing any symptoms initially.
I will answer the question in two ways. Echocardiography is not a very expensive investigation, so it is not a wrong practice to do an echocardiography and an electrocardiography in all antenatal mothers. It's not wrong. However, one should lower the threshold if the patient is more symptomatic. Pregnancy itself causes a degree of effort dyspnea, sinus tachycardia. So, one should lower the threshold. Doing an echo is just 2,000 rupees. I think one should definitely consider, more so in a patient who is disproportionately symptomatic than what is expected in a usual pregnancy. I do not know, maybe obstetricians in this group can answer that question, whether they routinely ask for an echo in every pregnant mother.
Okay, and one more thing, in terms of supraventricular tachycardia, is there any role of elective cesarean section, or should we go for normal vaginal delivery? What is your...
Absolutely not. The mode of delivery is decided on obstetric guidelines. The presence or absence of supraventricular tachycardia is absolutely not a reason to convert one form of delivery to the other delivery. In fact, vaginal delivery is the safest form of delivery in most of cardiac conditions, or regional anesthesia, not general anesthesia.
Thank you very much. Over to the floor. Anyone would like to ask any questions?
The most safe and the documented and the tested beta blockers are propranolol and metoprolol. Probably we should stick to the beta blockers which have the largest safety data. So to answer that question, instead of bisoprolol, probably we should give metoprolol and propranolol. The beta blocker should not be given as atenolol because it causes significant IUGR.
Okay, fine.
But bisoprolol may be given, but I would prefer metoprolol or propranolol in pregnancy because it has the largest safety data. I already briefly touched upon that. If there is good myocardial recovery, which happens in nearly 50% of the patients, if the ejection fraction is more than 50%, they can have. But if the ejection fraction continues to be less than 50, it is better to avoid a second pregnancy.
Your opinion about adding anticoagulants like the apixaban in patients with atrial fibrillation, its safety in pregnancy?
That's an excellent question. In fact, I wanted to highlight the so-called directly acting oral anticoagulants that you are alluding to is not the drug anticoagulation of choice. You should avoid the Dovax during pregnancy and stick to only vitamin K antagonists like warfarin, and that is also best avoided in the first trimester. You can give in second trimester up to preferably the last month of gestation. You can give vitamin K antagonists. It is best avoided in the first trimester, and the drug to go is low molecular weight heparin. Or if somebody cannot afford unfractionated heparin, but that is definitely not it's not good to give unfractionated heparin because it can cause osteoporosis, it can cause heparin-induced thrombocytopenia. So low molecular weight heparin in the first trimester, switch to heparin even unfractionated in the last 2 weeks of gestation, because you stop it, the effect goes away. 12 hours to 24 hours you stop and the patient can have. And it is good to resume anticoagulation 12 hours or 24 hours after delivery. 12 hours after vaginal delivery, 24 hours after cesarean delivery if the patient has a high CHADS-VAS score. But the directly acting drugs are better avoided in pregnancy. We don't have data.
Any more questions from the floor? Okay, then we will end the session. Thank you, the organizers, for giving us an opportunity. Thank you, Dr.
Thank you very much.
Check. Thank you, Dr. K U Natarajan, for that insightful and practical session on managing arrhythmias in pregnancy and also on heart failure.